basically what I put through in this next couple of slides is a talk where I would talk about dry eye following cataract surgery, and also about ocular surface problems, especially epithelial and corneal problems, which are related to the dry eye, as I have seen in my practice as a referral. So at the outset, we need to understand that the incidence and prevalence of dry eye after cataract surgery is greatly underestimated. Uh, and it can vary anywhere from 10 to 35%. And I think we need to look at all patients undergoing cataract surgery to see whether they have any of these factors either before or after surgery. Unfortunately, most patients, you do an excellent surgery, but following surgery, after a few weeks, you suddenly find you have converted a happy patient into an extremely unhappy, irritated, and frustrated patient. And therefore, we need to look at what are the causes, the risk factors, how can we prevent it, what are the early diagnostic approaches, and what should we do to treat these patients. So some of the factors in the preoperative period may be, for example, elderly age, the presence of dry eye disease preoperatively, which may or may not be picked up by us, the presence of meibomian gland disease, and the use of several drops preoperatively may add to the problem of the dry eye situation. During surgery, of course, we sometimes put a lot of drops. We might use large corneal incisions in some patients where the nerves are getting damaged, or we could do a longer surgery where the various factors dry out the surface and tend to cause problems. And in the olden days, we also had sutures, which would add up to some of these problems. Post-operatively, the use of drops with preservatives, antibiotics, and NSAIDs might further make things worse. So what typically happens in the post-operative period may be toxicity. This could be to preservatives, maybe antibiotics or non-steroidal anti-inflammatory drugs. And all these can give rise to ocular surface staining or might lead even to the development of an epithelial defect. We know that patients with dry eye are more prone to toxicity because of the delayed tear clearance, and these medications last longer on the ocular surface. The dry eye by itself can also cause epithelial damage. Similarly, we can have patients where there are neurotrophic factors, which could be either because of corneal incisions and cutting the nerves, or it could be because of systemic disease or previous treatments. The cornea may be anesthetic. There could be viral or some other etiology where the cornea is anesthetic or has poor sensation. These eyes are predisposed to dry eye because of a drop in tear secretion. And they also have healing problems because of corneal loss of trophic factors. Similarly, we could have some patients may have a subtle viral disease which could get reactivated and come post-surgery with surface problems and then into an epithelial defect. Patients with poor sensation more prone to trauma while putting drops, which might complicate things. And as I said, sometimes tight sutures can cause Dellen effect and cause dryness of the ocular surface. So can we really predict what is going on? So we need to see them preoperatively, at least beyond the cataract and before the cataract, start looking at the tear film and the ocular surface. We may not have all the time to do Shermers and significant amount of testing, but we need to look at specific clues. There are several high-end equipment like this. We do a lot of testing. However, most small practices neither have access nor have the time to do all these testing. So we need to look at simple things. For example, when you do your biometry, the keratometry Myers are distorted. It should be an indicator that there's something wrong, or the presence of froth on the ocular surface, or the presence of meibomitis, how the glands express out when you squeeze them. So these are some simple clues that we must look when we do a cataract surgery workup. And if you have sophisticated equipment, you can do more sophisticated testing. We are all aware that preservatives can impact the ocular surface, make things worse in an eye with significant epithelial damage to the corneal surface with the use of these drops. And for early diagnosis, just like any other dry eye patient, we need to listen to the patient, look at symptoms that he is complaining to us, do a little bit of fluorescein staining, which can help us to pick up early staining, and then closely look at these patients to figure out what's happening. In most of these patients, once you pick up the problem early, you can always treat it quickly by stopping the preserved drop, stopping the non-steroidal or toxic medication, using preservative-free steroid drops, preservative-free lubricants, try to manage the MGD, and maximum you may require some oral doxycycline. And most of these patients with careful follow-up do pretty well if you pick it up early. So basically, when the cataract workup is done, we need to do a little bit of dry eye workup, which may be symptomatology, looking at the glands and the surface, and a little bit of staining. If you do pick up dry eye, I think we need to treat it before we do the surgery. If you pick up only risk factors in a given patient, no real dry eye, then maybe you need to be very cautious and monitor them more often post-surgery. If everything looks normal on the ocular surface, just go ahead and do your routine surgery. However, all patients need to be keep monitoring for early symptoms, modify the treatment if you look at any or you find any early symptoms, and keep watching them a little bit more frequently. However, when we miss some of these early changes, we have a patient who walks in irritated and agitated, and there you have the dry eye situation with the where you need to treat them a little bit more aggressively. This cycle of events happens in most situations, gets the cataract surgeon picks it up early where the patient complains of redness and irritation. So the surgeon would normally put more drops, tell him to step up medication sometime on telephone, only to find he's getting worse. So if the surgeon can pick it up at this stage and make changes in the treatment, the patient will usually recover quickly. However, in rare situations, the condition continues to progress. Sometimes antivirals are given, and the patient continues to worsen and then walks into the cornea clinic with an epithelial defect or a stromal melt. And then it's a little bit more difficult to manage these patients. And in these patients, again, we need to look at cautiously for an aqueous deficiency, for evaporative dry eye. Always look for corneal sensation, the list of medications that have been used in the past, whether there has been any trauma while putting drops, presence of any subtle scars, opacities, or an irregularity on the ocular surface which might predispose to dryness. Again, most of these problems can be treated just the way we treated mild cases. However, occasional patients might require that you need to look for infection, need to look for autoimmune conditions where you may need immunosuppression, look for corneal melting, and you might have to do a bandage lens or a tarsorrhaphy. So these are some of the more difficult cases that you will see as a cornea specialist in your clinic, which need a little bit more different approach. And sometimes it's difficult to figure out whether this is viral or not viral, and you have to take a decision as to how to treat them. This was just a patient who came in with tight sutures, a large epithelial defect, and you can see ciprofloxacin deposit. However, he recovered well once you realize the basic underlying pathophysiology. So in conclusion, I would,
doctor.
Yeah, in conclusion, I would say that preoperatively avoid too many preserved drops. Always look at the ocular surface and try to optimize it. Quick key is to look at the keratometric Myers, which will tell you a lot. Be careful while using topical antibiotics, non-steroidal anti-inflammatory. Delay surgery if you feel you're not comfortable with the ocular surface picture. During surgery, reduce the number of drops that you put or irrigate the surface. Use a viscoelastic on the cornea rather than using constant irrigation, and try to do surgery with a smaller incision. And be careful, especially in patients who have dry eye, if you want to use a premium IOL. Post-surgery, you can always use artificial tears. Whenever you feel there is a problem, avoid non-steroidal antibiotics, anti-inflammatory drugs, and epitheliotoxic antibiotics. Be cautious if you have especially done a premium IOL, because these patients will be very unhappy with the results once they have a dry eye problem. And whenever need be, see them more carefully and more frequently so that you can avoid getting into trouble. So with these few preventive steps, I think we can manage most of our cases successfully in practice, and we may not even need them to send them to a cornea surgeon. Thank you all of you for patience.